Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one-size-fits-all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy with Marvin Goldfried and my long-term friend and colleague,
Alan Francis.
Alan Francis. Sorry, I stepped on your words.
You can step on me anytime you want, Marvin.
So listen, today we decided we're going to talk about self-disclosure. Now, you with your heavy-duty analytic training, I'm curious, what did they say about self-disclosure in your training?
They said a lot, but I didn't listen much. The model that came to American psychoanalysis was not really what Freud practiced.
Yeah.
It was a kind of idealized, you're supposed to be a blank screen.
Yeah.
That the patient could project onto you their own fantasies, uncontaminated by what you are really like. Mm-hmm. And that would create the purest transference that would give you the clearest field to understand and to work with the patient's own fantasies and distortions. Freud himself was the exact opposite. So everyone knew everything about Freud. Most of his patients came to Vienna. They're mostly English speakers who came to Vienna because they had read Freud. They knew everything about his life. His students were also his friends and his patients. He taught constantly in the sessions. He was very self-disclosing. He took patients on vacation with him in the summers. So he was the opposite of a blank screen.
Where did this come from, this blank screen thing?
The blank screen, I think, was the idea of creating in the analytic situation a kind of sterile surgical field that would be uncontaminated.
No, I understand the concept.
Who did it?
Who promoted it?
Mostly the Germans. The German psychoanalytic out of Berlin was much stricter than the Vienna school. And the most prominent, there were people from all over Europe, the great psychoanalysts from all over Europe came to America to escape the Nazis. And they were the American psychoanalysis was basically a transport of European psychoanalysis. The most powerful people had come from Germany, and they had the strictest interpretation about self-disclosure.
That's interesting. I mean, a lot of people are confused about it. I had a colleague who was a few years back was teaching a clinical practicum, and he told the class, under no circumstances should you reveal anything about yourself. And I was teaching them the opposite. And I was saying self-disclosure is very, very important. So it's hard, how could you not reveal anything about yourself when a patient comes to your office, sees how it's decorated, sees how you're dressed, sees your mannerisms, and now with therapy over TV, and a lot of people doing therapy from home, the fourth wall has disappeared very often. So it's very, very hard to hide things.
Yeah, in terms of the American psychoanalytic movement, Harry Stack Sullivan, who was the greatest of the American psychoanalysts, the only one who made a real contribution to theory and technique, introduced the interpersonal element in the treatment.
Yeah.
And the more you think about the relationship being an important engine of change, the more you realize that if you act like an unnatural blank screen, you're going to be forming a very distorted relationship that was less likely to be healing. And so the supervisors I loved best when I was training were the ones who allowed me to be myself with patients. We're being able to smile, being able to respond in a way that was normally human, that was caring, that was intimate, where that would be a very important part of establishing the kind of healing relationship that would create the corrective emotional experiences that were the foundation of change.
Can you say more about that? Because I think that is, one of the big and important arguments for self-disclosure, to establish the relationship.
Well, I think part of it is that if you don't at least reveal your emotions, your reactions, your empathy, if you're a stiff blank screen, you're creating an environment where many patients will not understand why you're doing this for technical reasons and will reject you and reject the treatment because they experience it as cold and unfeeling. Now, there are certain patients and certain analysts who can develop a kind of blank screen relationship that works, but that's the exception. The one thing I would say, though, is that self-disclosure also has great dangers associated with it. And the therapists who are most inclined to self-disclose are often the ones who should least be doing it.
Yes, I think I know what you mean. But let's come back to that and talk about the benefits first, because I think that's really important. That's the message we're trying to get across, and then we can talk about some of the caveats.
Well, I think you've written a paper on this. Why don't you describe some of what those benefits are?
Yeah. Well, certainly one of them, and an important one, was what you're saying. It's establishing a relationship, of a trusting relationship. And it's one human being working with another human being. And as Sullivan said, to quote Sullivan, one of them knows a little bit more, as he described the therapist as an expert in human behavior, and is there to help the patient. So it's a relationship between two people. And that relationship is so important in so many different ways. It could be used as the direct vehicle for change if the person has problems in relationships, or within an orientation such as CBT, it involves the background context through which patients will have their corrective experiences between sessions. So it could be healing within the session, or it could be the way of encouraging patients to go out and do things between sessions that are going to be healing. And so from that point of view, it's great. But I think there's lots of other ways too that are not immediately apparent. And here I cite the work of Albert Bandura on modeling. And it's unfortunate that has been lost to contemporary therapy, and even within CBT, because Bandura was his work was one of the main foundations in the United States for the development of CBT, as we indicated in a previous podcast. And his notion on modeling is that it provides a form of learning. And he demonstrated this very, very clearly in controlled studies. So you have the observer who observes somebody who is functioning in a certain way, and that observation helps the observer to increase the likelihood they're going to function in that way. And I'm being very general right now, but that's his overall bottom line. So it helps people change. And the last time I looked, that's what therapy is supposed to be about, to help people change. So self-disclosure can allow the therapist to serve as a model for the patient.
Do you want to be a little more specific and maybe give some examples?
Yeah, okay. Patient may have a certain reaction and may be in a situation where they did something, made a mistake, and felt terrible. To the extent that the therapist feels comfortable in indicating that they also have made mistakes, it's like this is part of the human condition. And I'll give you an interesting clinical illustration here. I was supervising a graduate student who came in and described a session that she had with a patient where she really didn't do a good job, and the patient left somewhat concerned. It wasn't disaster. So during supervision, I said, you have to deal with this. You have to kind of let the person know that you were not at your best, and just indicate that. And then she said, I can't do that. And after supervision, which consists of a little bit of verbal arm twisting and giving a rationale, she went out and she did it. And she comes back the next session. And I said, well, how did it go? She said, it went really well. And I feel so much better for doing it. But something even more important, the patient then said afterwards, toward the end of the session, the fact that you have apologized for making a mistake was so important to me because it gives me the freedom to make mistakes. That was not necessarily the intention, but that was the impact.
Yeah, and it's amazing how moments like that congeal what therapy is all about. That's one of those magic moments.
Yes.
And I think, like, I've had the experience any number of times where saying that I've never learned from the things that went well in my life. I've only learned from my mistakes.
That's right. A lot of people, I think that somebody well-known said it, that you don't learn from your successes, you learn from your failures.
And I've also revealed to patients that every time I really wanted a job or wanted something and I didn't get it, and I might be crying about not getting it, it turned out it was great I didn't get that job. That the disappointments in life often turn out to be the luckiest things to ever happen.
Yeah.
And in doing that, you're saying, I've had mistakes, I've had failures, I've had disappointments, and somehow or other it worked out okay. And it gives a sense of hope for them that what seems to be the beginning and the end of their lives because they've made a mistake or because they haven't gotten a job isn't necessarily as important as catastrophic as they feel it is at that moment.
Yeah. Right. So that's one example. Another example, which I think is really important, is that research by Bandura has found that when an observer watches a model, they're more likely to engage in the behavior of the model. Now, professionals know this, probably the only thing they know about Bandura, because it's in the introductory psych textbooks, where children would watch somebody hitting a Bobo doll, and then it would increase the likelihood they would do exactly the same thing as the model did. So he used this as an example of you can get a person to behave in a certain way, and in this case, it was an aggressive way, by observing models. And this happens all the time. Our parents are models. Parents don't realize that the way they are affecting their kids in their parenting is not only how they interact with them and what they tell them, and how they respond in a positive or negative way, but also how they behave in the world as well. And that there's kind of a sleeper effect where somebody can observe a parent parenting, and this pattern of parenting won't come out until they themselves become parents. So it's a very powerful and sometimes implicit change process method.
But I think the reason it's so powerful is it's so built into evolution that probably the most characteristic thing of every social animal is the impact of modeling.
Yeah.
Social learning isn't something restricted to human beings. It's how all social animals function. And many species have cultural tendencies that come precisely from modeling.
Exactly.
We're prepared learning. We're prepared to learn by modeling what we see others do. It's part of who we are. It's built into the hard wiring and the soft wiring. It's no surprise then that a very powerful part of therapy is the therapist being who he is. And it's one of the reasons why therapists who aren't genuine are modeling non-genuine behavior.
Yeah.
Therapists who are stiff are modeling stiff behavior. That's not what you say so much. It's not the brilliance of the interpretation. It's what you're like as a therapist.
Yeah. You know, you're talking about animals learning. In the 1940s, Miller and Dollard and Miller went on to write something else later in 1950, but in their 40s, they report on a series of research studies that they did where rats would imitate other rats. So the issue is, how can you get somebody or an organism to change? Well, a rapid way to do it is by having them watch somebody else doing it. So imitative learning becomes very, very important. So if a person says, well, you know, I don't know if I could speak up in this situation to my supervisor. And if the therapist has had an experience where they have had difficulty but overcame it, that self-disclosure can help the person in a very, very powerful way. It's like, well, I remember having difficulty once with a supervisor, and I was so afraid, says the therapist, that I get yelled at, but I really had to do it, and I spoke up, and much to my surprise, everything was okay. And that was a very important lesson for me. So the therapist is self-disclosing, serving as a model for two very important things. One, the reduction of fear, and the other, the demonstration of an effective behavior. Very, very powerful.
And a third thing is humility.
Yes.
The willingness to admit having had similar fears, similar concerns, similar inhibitions, and having been able to overcome them. And it puts the two people on an equal plane.
Yeah. And it doesn't have to be a big deal. So a patient in his or her 50s says to you, you know, I'm having such trouble remembering names. And you as the therapist can say, yeah, what else is, by the way, what's your name?
Tell me about it.
What's that?
Tell me about it.
Tell me about it. Yeah. But here's the thing, you've got to think before you do it. And maybe we should talk a little bit about some of the problems associated with it. What did you have in mind with some of the problems?
Yeah, the self-disclosure always has to be for the patient's benefit, never for the therapist to get something off his chest, or to be exhibiting, or to be using the patient as a shoulder to cry on. The self-disclosure in therapy is because it's good for the patient, not because the therapist is out of control or has his own personal needs met by the patient.
You think some therapists are narcissists?
Yeah. And some therapists are dependent, and some therapists have bad days and they feel sad. And it can be what's meant to be self-disclosure in the interest of the patient can sometimes be self-disclosure because the therapist is not able to contain their own needs and uses the patient and exploits the patient through self-disclosure. Yeah.
Well, interesting little vignette. I once did a study on master therapists of different orientations. And I had my secretary type up the sessions into transcripts. And there were some instances of well-known therapists who were participating in this, who will certainly be nameless, I will not disclose that, talking about themselves in a self-aggrandizing way, which we coded as self-disclosure because our coding system was self-disclosure. And the secretary said, I don't like this person. They're bragging. So the question, actually, there are two questions. which is a simple rule of thumb that I use. And it's a very rapid rule of thumb now because I've used it a lot, but I teach it to supervisees. When you're about to self-disclose, you ask yourself two questions. Why am I doing this? Why am I doing this, and who am I doing it for?
Yeah.
But the why am I doing this? It's like, is it to brag? Is it to build myself up? If so, why? Is there a problem in the relationship? No. I just want to build myself up. That's not what I'm here for. I'm here to help the patient, not necessarily to build myself up. So that's a question that you have to ask yourself very, very quickly and respond very, very quickly. And this is, of course, why therapy takes so long to learn in a very effective way, because you just need lots and lots of practice. So these things can occur very quickly because they occur in real time. Why am I doing this? I want to reduce the person's anxiety. I want to normalize the patient's behavior. I want to just establish and reestablish or strengthen a bond. I want to, whatever it is. And then the second question is, what's the likelihood this is going to have an impact on this patient? So I've had sessions with some people where the first question was, yes, I want to do this. It's a good thing. And then I self-disclosed, and the impact on the person was nothing. And I could see a blankness on his or her face. And my thought was, this person is not responding well to self-disclosure. I better stay away from that for whatever reason.
Yeah, and I think that self-disclosure is most powerful when it's not done often. So if a therapist is constantly self-disclosing, it loses any particular poignancy and specificity. It's something you do with, as you put it, a very specific reason at a specific time, because you expect to make a big impact in doing it. It's not part of normal chit chat in a conversation to be self-disclosing.
Yeah.
When you disclose something, you should be going for a home run. There should be something important that you hope to gain from it.
Yeah. Why am I doing it? And is this what's the likely impact with this particular person? Which of course you won't know maybe early on, but after a while you know that this is not something that you do.
And let me say, it can be a deal breaker that the treatments end sometimes because of self-disclosure. Particularly narcissistic patients need to have their therapist be great. The therapist may feel, I'm going to self-disclose to prove that I don't have to be great. I don't have that need. I'm going to model humility. And the patient may then completely discount everything the therapist will ever say again. Oh, he's even more screwed up than I am. Mm-hmm. He's not the great person I expected him to be. If he has any flaw, he can't be my therapist. Only the best person in the world can treat me. Right. Yeah. And the person who has a flaw is no longer capable. The risks of exploiting the patient or losing therapeutic leverage with self-disclosure, or losing the specialness of it if you do it too often, are sufficient. That should always be held in reserve, as you put it, I think brilliantly, held in reserve for, why am I doing this now when I usually don't? It shouldn't just be the common technique and language of everyday therapeutic discourse. There should be a reason for doing it. And a self-inquisition, I'm doing this for the patient. I'm not doing this for myself.
Yeah. And, you remember in a previous podcast, we spoke about Carl Rogers and the case of Gloria, where toward the end of the session, he mentioned to Gloria that, well, I kind of think you would make for a very nice daughter. and so he self-disclosed, even though the model says you're not supposed to do that. And I guess it was, his answer was glib. He says, well, I'm allowed to do this because I'm Carl Rogers. I don't have to be Rogerian. But it's interesting to speculate. And some people have, and I don't know what their conclusion was. of why he did it. And I think it was just a human impulse of wanting to just connect with this woman who was having trouble connecting.
And that's a beautiful statement, isn't it? I mean, what could be more affirming than that statement that he made?
Yeah.
But it's interesting to me that people should self-disclose less when they're earlier in their careers.
Yeah.
It's something you grow into. You get more experience and more comfort, more self-knowledge. For beginners, it's a mistake to be completely stiff and act like a blank screen or like a robot or like a manual kind of person applying a manual. But I think that for beginners, you gradually grow into self-disclosure. It's not something that you don't pour your heart out.
No.
Patients.
And you know what would be wonderful for training purposes is to have a series of videos that beginning therapists could watch, and even more advanced therapists, of different examples of self-disclosure, and when it works and when it doesn't work, so that they know, here's the arena you should stay within, and here's the arena you should avoid, so that they don't have to wait for 10, 20 years of experience to be able to have these instances, and they can have it right in front of them.
That'd be great. And I think the other thing for people to keep in mind is don't self-disclose things that are bothering you at the moment. The self-disclosure for things that problems you've had and you've solved.
Yes.
You have a degree of distance and comfort. If there's something that's bothering you in the moment, you don't want to be discussing it with your patients.
Exactly.
Your problem with yourself, with your therapist.
Yeah.
Your patient should never become your therapist.
Right, because you're too emotionally involved, and never underestimate the ability of emotions to make us behave stupidly.
Yeah. We shouldn't become dependent on our patients in a way that's going to be harmful to them. We should be dependent on them in a way, but not in a way that's harmful to them. This brings up an idea for next week.
What's that?
Discuss giving advice, which is another controversial topic.
Okay. You have enough to say?
Do I have enough to say? I never have enough to say, but stuff comes out.
Well, I'm sure.
It may be BS, but the mouth always works.
Okay. Listen, as we advised a little earlier, it's okay if we make mistakes, right?
Yep.
Okay. Talk to you next week. Stay safe. Bye-bye.
It was a pleasure.